So this lecture is going to correlate with Chapter 60, which is another part of the endocrine system, and it will cover drugs that affect the adrenal cortex. So let's first take a look at the hypothalamus and pituitary gland again. If you look up here, you can obviously see that there's the hypothalamus, the pituitary, and the anterior pituitary also has one effect that affects the adrenal cortex. So that's what we're focusing on today. So let's look at the hormones that are produced within the adrenal cortex. It affects multiple processes throughout the body. It maintains glucose availability. It regulates your water and electrolyte balance. It also has a small effect on the development of sex characteristics. And it also has life-preserving responses to stress. So if you take a look at this chart down here, what we're going to be discussing are the drugs that affect the cortex, which is right here. So this includes medications such as glucocorticoids, mineral corticoids, and like I mentioned, there's a very little effect on sex hormones. So we're mainly focusing on the above two. So as you notice, glucocorticoids, they raise blood glucose levels. They stimulate glucose production by the cells, and they also reduce the inflammatory response. So a lot of times you will see glucocorticoids used in multiple disease states. This lecture is mainly going to provide coverage of insufficiency and excess adrenal hormones. If you look at the mineral corticoids, this acts on the distal convoluted tubules of the renal nephrons. So this is where you get the regulation of the sodium and acid-base balance. If you look up here at this chart, you can see there's a picture of the kidney, and the adrenal gland sits right on top of it. And the adrenal gland is divided up into two sections, essentially. We look at the medulla, which is in the middle, and then we also have the cortex of the adrenal gland. So right now we're actually focusing on the cortex, which is where we get the glucocorticoids and the mineral corticoids. If you look at the medulla, and if you look at PNS and CNS systems, that's where you can find the epinephrine and norepinephrine. So same thing with any other hypothalamus pituitary regulation system. It's a negative feedback system. So, it all originates up in the hypothalamus, and there's that communication with the pituitary gland, and then it goes down to the adrenal gland. And then, like everything else, it's sensed, and then it kind of shuts off, turns off, or turns on these stimulating factors, or that want your body to release these hormones to get it activated again. So let's take a look at glucocorticoids first. And we're going to look at the physiologic effects of glucocorticoids. At low levels, it helps with carbohydrate metabolism and protein metabolism and fat metabolism. It has that positive effect on the cardiovascular system if it's at a correct level. It affects our skeletal muscle, our central nervous system, and it also helps with the stress response. One other thing that it also plays a role in is the respiratory system in neonates. And I put that little box up on there for fetal lung maturation, because a lot of times this is like a side note, but sometimes glucocorticoids are used for the mothers at risk for preterm delivery. They actually will administer a dose of steroids to the mom before the baby's born, because this will actually stimulate fetal lung development. That's just another little side note on a glucocorticoid. Now, when we look at glucocorticoids, obviously we need them at a correct level for our body to function properly. However, when the system is gone haywire or we're producing too much, you have adverse effects. The other thing too, if a patient's on high-dose steroids for a long time, they have the same symptoms as if you had an organic issue that causes higher steroid levels within your body. So Cushing's, which we'll talk about in a few, is actually a state where there is a high production of steroids within the body. So there's obviously adverse effects with that. So if you take a look at this chart here and you look at on the left side, there's psychiatric issues that can develop from it. And sometimes you may hear this too, like a patient that's on steroids for other reasons. Sometimes they say, oh, they have mood disturbances or they can't sleep on it. They feel like they're too stimulated from it. So they can have, psychiatric issues with it. There's a lot of skin changes with it if they're on it. dose that's higher than it should be, they can also have issues with their skin. It actually will thin, and sometimes they get stretch marks on their stomach. Neuro, you can see neuropathy, cardiovascular. If we're getting too much, it can actually develop hypertension. One of the more prominent symptoms that you will see a lot too with patients that are on high dose steroids for long periods of time, they do get bone loss. So you'll see a lot of osteoporosis within those patients. So anybody that's on steroids for a long time, we always will keep an eye on that and make sure that their bones are healthy. Endocrine, it has an effect on that. If you have levels that are too high with the steroids, they are more at risk for developing diabetes. Anytime a patient that's on steroids, their blood sugars usually rise with it as well. Their immune system, steroids cause immunosuppression, so a lot of times patients can get more sick if they're on these. Their immune response isn't great. And then ophthalmic, they can also have a history with cataracts or glaucoma. Those are also could be potentiated with this. In terms of development, this is more common, obviously, with children. Let's say, for instance, we have a patient that got asthma, severe asthma where they have to be on steroids a lot, or another, physiologic state where they need to be treated with high-dose steroids. They can have a reduced growth. So their growth isn't as great as it would be. So that's something that we always keep an eye on too. Now we look at mineral corticoids. So these are a little bit different. They're corticosteroids, but they're different than the glucocorticoids. This has the effect on the renal system. So the processing of sodium and potassium and hydrogen. We have aldosterone, and that promotes the sodium and potassium homeostasis. So this is going to maintain your intravascular volume. And obviously, if this gets, off, or if we have high excess doses of it, they can have harmful effects on their cardiovascular system. And a lot of this is regulated by the renin-angiotensin-aldosterone system. So we're going to talk about adrenal hormone excess. So we're looking at excess of these hormones. Cushing's syndrome is the top one that you will hear related to this. And the causes for it, there's a few different causes. It could be hypersecretion of ACTH or hypersecretion of glucocorticoids, or it could be external from administration of glucocorticoids. So it could be something within the patient, or it could be some kind of medication that actually is inducing this. So what the patient will present with, they actually usually will present with obesity, and a lot of times it'll be central obesity around the abdomen. A lot of times they have hyperglycemia, glucosuria because they're spilling glucose into their urine, hypertension, fluid electrolyte disturbances. So it kind of goes along with all those factors that I kind of already talked about. So if you look over here at this side, you can see pictures of a child that was normal right here, and then all of a sudden you have effects of Cushing's, and you can see that there's abdominal obesity. Another thing too is that they will develop usually like a fat pad up on the upper back neck. A lot of times they'll have muscle weakness and then issues with their skin, and then it can affect their bones as well. So I put this on here too. It's just one of those mnemonics that you can look at for Cushing syndrome to kind of help you remember some of the factors that go along with it. So these symptoms that you notice with Cushing syndrome is what you would notice in a patient that is on chronic steroid use. That's honestly that. Usually it's not just like those lower dose steroids. Usually it's high dose steroid use. You'll see this more like, for instance, if a patient had a transplant, they'll put them on steroids to they have to be on steroids so that their body does not attack the transplant organ. So sometimes these people, these patients will have issues with being on steroids for a long period of time. And a lot of these symptoms are very similar to Cushing syndrome because they have the same underlying cause of having high levels of steroids in them. So like I mentioned, they can have some mood development changes, hyperglycemia. Sometimes you'll hear it referred to as moon face, and that's just basically their face will round out, and it's just, it's more round and full. They're more susceptible to infection. They can affect the sex hormones. So males will, sometimes can develop mild gynecomastia. And essentially what that is that they'll get more growth of the tissue around the breast area. And then the other thing too, like I mentioned, the fat deposits on the back, the upper back or the back of the shoulders, osteoporosis. Another thing too that you always keep an eye on when a patient's on higher dose steroids or if they have Cushing's, they can have an increase in stomach acid. So a lot of times we're at more risk for development of peptic ulcer disease. Another thing too, like I mentioned, you look at their skin, there's issues there with that, and a lot of them end up with fluid retention or edema. Now, if you look at a patient down here on the right side, this is a female patient. This was, if you look at picture point A, this patient, this was before the onset of Cushing's disease. Now, if you look at this patient on the right, it's the same patient. This is after she was diagnosed with Cushing's disease. You can see that there's that development of the fat pad above there, and you can just see that the overall rounding of her face and all that too. So you can see the changes that these hormones can affect in the steroids. So we're still talking about Cushing syndrome. So treatment of it, a lot of times you have to determine the underlying cause of it, like I was saying. A lot of times it can be related to a pituitary adenoma. And this adenoma, kind of throws the feedback system off, and that's where they get this overproduction. So you kind of have to treat the cause here. So it's surgical removal of the adrenal gland. It could be on the adrenal gland, or it could be arising up from the pituitary. So you have to determine where it's coming from first. And that's not really what I want you to know truly. I want you to understand what steroids are and glucocorticoids and what happens when they're elevated. That's what I want you to focus on. I'm just trying to explain the physiology and patho here. So a lot of times drugs are used in treatment with surgery. The other drug that's used a lot too is ketoconazole. It's actually an antifungal agent, and it's used in adjunct to therapy to help suppress the adrenal cortisol production, so it'll help reduce that production of cortisol. It's used in higher doses too. It's not used at the typical dose you would use for an antifungal. It's used up around 600 milligrams, which is a really high dose. So that's kind of used as an adjunct therapy with this. So now, actually, I'm going to go back to this. So now if you're looking at this and we're going to do, let's say, for instance, the patient has surgical removal of the adrenal gland. So now, because it's kind of like the thyroid thing. If they were, producing excess thyroid hormones and it was due to, Graves' disease or thyroid cancer, and they had to remove the thyroid. Well, once you do that, same thing with this, once you do surgery with the adrenal gland, it puts them the opposite way. So a lot of times these patients have to be treated for insufficiency after this. Hopefully that makes sense. But you're basically putting them into adrenal insufficiency after treatment for excess. So now we'll go to this adrenal. So this kind of puts us into place about talking about adrenal hormone insufficiency. So like I said, it can be brought on by having, Cushing's disease, or having, a pituitary tumor, or the adrenal surgery. So it essentially throws them right into an insufficiency. Or there's adrenal hormone insufficiency that's on its own as well. So usually what we do, obviously, is have to replace their glucocorticoids. So we have to give them steroids. When we do this, we want to mimic those normal patterns of corticosteroid secretion. So when you hear about like cortisol, like you hear about the stress hormone cortisol. So our cortisol levels fluctuate, obviously, with our diurnal activity or circadian rhythm. So a lot of times in the morning, your cortisol levels will be increased, so they'll get up higher, and then they kind of drop down through the day. However, those fluctuate with times of stress. So what we're trying to do is simulate this with their dosing. The other important thing to kind of understand here, the doses that we use of steroids for these endocrine disorders are much smaller than what they are used for, like if you were using a steroid for like asthma, or an acute issue with asthma, or if we're using it for rheumatoid arthritis to suppress inflammation. Those are usually short bouts of steroids, but they're usually higher dose steroids when we give them. This is trying to maintain that normal rate at which your body would produce these hormones and these steroids. So usually what they recommend is taking 2/3 of the dose in the morning and 1/3 in the afternoon. However, some physicians, some practitioners will provide the dosing just for the morning, and they just kind of try to follow that normal activity. The important thing to understand is anytime a patient is in times of stress, if they were having surgery or if they were ill, these dosages have to be accommodated for this, because obviously your normal cortisol levels will be rising in times of stress or in times of surgery. We have to simulate that with the hormones that we are replacing. So I put a little picture over here because there's an alert. Patients with adrenal insufficiency should have a band on or some kind of way to, if there was an issue where there was an emergency, that people recognize that they have this because if they're really ill, we have to know this and make sure that they're treated appropriately. So now when we talk about, we're still talking about insufficiency here. Now we have what we call Addison's disease too. Addison's, so this is separate from, if we were to have surgery and remove it, this now is actually an actual cause of insufficiency. Addison's disease is a primary adrenocortical insufficiency state. President Kennedy had this. I don't know if anybody knew that. Just it's an interesting little fact. Clinical presentations and causes. They a lot of times will present with weakness and hypotension, emaciation. So they actually will have, issues with their weight and all that and keeping that up. Hypoglycemia they'll have, hyperkalemia, and hyponatremia. So like I said, before with the sodium and potassium, that gets out of whack with this too. So it's almost exactly the opposite of having an excess. Treatment is to replace with corticosteroids. The number one drug that we use to replace is hydrocortisone. That's the drug of choice. The reason being is that because it has both glucocorticoid and mineralocorticoid properties to it. So when we replace, especially in a patient that's not producing their own, we have to make sure that we're getting both in order to cover both areas, the glucocorticoids and the mineralocorticoids. So hydrocortisone is a good treatment option because of this. So now when we talk about Addison's disease, there can be a few different reasons as to why they get this. It can be a primary or secondary or tertiary. Primary, I put these arrows down here. Primary originates within the adrenal gland. So that's actually within the adrenal gland and that's dysfunctioning there. Now, if we look at secondary, they're getting a decreased secretion of ACTH. So that's coming from the pituitary. So that's secondary. And then tertiary can be affected from the CRH, which is originating from the hypothalamus. So just like any other thing, like if you were looking at the thyroid, it can originate from up in the brain at the hypothalamus or the pituitary, or it can originate like within the adrenal gland or the thyroid. So it's the same kind of, it's the same process. Like this can happen within the central or peripheral areas. In either case, the adrenal secretion of glucocorticoids is diminished. So in both cases, with secondary and tertiary, the glucocorticoids are diminished, whereas when the secretion of the mineralocorticoids is actually normal. So treatment for this is replacement therapy with glucocorticoids, but usually they use hydrocortisone for this one as well. This next image will it's basically going over what I just stated, basically. You can have adrenal insufficiency from a primary cause, which actually originates within the adrenal glands, or it can be a secondary cause, which originates within the pituitary or hypothalamus. So symptoms, I just put this up here too. A lot of times they'll have bronze pigmentation of the skin, which if you look in this picture, it kind of depicts this. If you look at their skin coloring, they'll actually will get that bronzy tan look. A lot of times they can have changes in the distribution of their body here. They have hypoglycemia, they can have postural hypotension, weight loss. So they, a lot of these are opposite of what you would see with Cushing's. So with this, they can have issues with the renal system. They'll have a low sodium, or they can have a high potassium level. So now we also have, in an area where we have insufficiency, is an acute adrenal insufficiency crisis, so adrenal crisis. And this is very dangerous and it can lead to death. Usually when they present, it would be hypotension, dehydration, severe weakness, lethargy, and GI symptoms of vomiting and diarrhea. The causes of this, like I said with the other ones, it can be originating within the adrenal or the pituitary, and it would be failure of both of these. Or you can also see this when a patient is on high-dose steroids and it's discontinued abruptly. They essentially, you're taking all that away, and then all of a sudden their body is not producing all this on their own, so it throws them into an adrenal crisis, essentially. So with acute adrenal insufficiency, treatment revolves around rapid replacement of fluid, salt, and glucocorticoids. And you want to make sure that they have glucose, so you're going to give them normal saline with dextrose or sugar in it. Now, another area where we also see adrenal hormone insufficiency is in congenital adrenal hyperplasia. This is something that is brought on during fetal development. Clinical presentation and causes. It's essentially it's a group of inherited disorders, and it has the fetus or the baby will have a reduced ability to produce cortisol. So it begins early in gestation, and it leads to disease that will manifest at birth or later. Without cortisol, there's not that negative feedback system there. So they're not getting that secretion of the CRH or the ACTH from the anterior pituitary. So they'll have unremitting stimulation of the adrenal cortex, leading to hyperplasia of it. So it's kind of like the same thing with the thyroid. If it keeps trying to stimulate, it's causing it to enlarge, and they'll get hyperplasia of it. Treatment, same kind of thing. They'll give them hydrocortisone. Another one that they use too is dexamethasone or prednisone. So screening with this is done with newborn screening, which I mentioned too within another lecture, but that's the test that's done on all newborn babies. So agents for the replacement of therapy in insufficiency. So replacement therapy with corticosteroids is required. They have to have some kind of corticosteroid going in. Glucocorticoids always required. Sometimes the mineral corticoid is required. So that's why a lot of times they use hydrocortisone, because it has both properties there. The other ones that we use, like I said, is dexamethasone and prednisone. Fludrocortisone is the only mineral corticoid available. So if the patient's doing a dexamethasone, they'll have to add the fludrocortisone with it to get that mineral corticoid availability. So let's just talk about hydrocortisone. This is a synthetic steroid with a structure that's very similar or identical to cortisol, or normal cortisol. So we use it in adrenal insufficiency. We also use hydrocortisone for allergic reactions or the treatment of inflammation. It can also be used in cancer therapy. The adverse effects of high-dose therapy of cortisone, it can have the adrenal suppression. So if they're on long-standing steroids, that normal feedback system becomes it's not getting utilized. So if you were to withdraw it, that system's not working properly at that point in time. And then if they're given too much, you can develop a Cushing's syndrome. The biggest thing too is into a patient that has Addison's disease. They always have to make sure that they have enough hydrocortisone or cortisone on hand if they do have times of stress, or if they're ill or having surgery. They have to make sure that they are properly being replaced. Now, prednisone and dexamethasone, these are preferred for oral therapy of chronic adrenal insufficiency. And like I mentioned about cortisone and hydrocortisone, they both have, I already mentioned this, they have both glucocorticoid and mineralocorticoid activity as well. Now, Florinef, like I said, this is a mineral corticoid. It's used in Addison's disease, primary hypoaldosteronism, and then congenital adrenal hyperplasia, because in that they're not producing any of the steroid hormones. So you have to replace both the glucocorticoid and the mineral corticoid. Adverse effects, hypertension, edema, cardiac enlargement, and hypokalemia. Now, if you gave excessive doses, they can have a retention of sodium in water and excessive secretion of potassium. So they can have expansion of the blood volume. So that's why you have to be careful too with the hypertension. That's where that originates. Same thing with the cardiac factors. It kind of all plays into one another. So when you're taking care of a patient that's that's on these, you always want to look at their weight, to look at swelling of the feet and their lower extremities. And observe for any hypokalemia that they may have, like muscle weakness or irregular heartbeats can happen with that too. So that's things that you have to be conscious of. Now, this is a chart that I put up too. This looks like the different types of steroids. If we look at the top, there's dexamethasone, hydrocortisone, prednisone, solumedrol, and then the mineral corticoid at the end. Now, if you look over here, we compare these all to cortisol. So if you look at the potency, you can see that Decadron is very, very potent. And like I was mentioning before, hydrocortisone is very similar to cortisol, or normal cortisone. Prednisone is 4 times as potent. Methylprednisone is 4 times. And this functions a little bit differently, so it's at a 0 essentially. Another thing too is these steroids have different durations of action. So you can see that some are longer than others. Hydrocortisone's got a shorter. And then the other thing too is when you're replacing and using a glucocorticoid versus a mineral corticoid, like I mentioned before, some of these have properties of a mineral corticoid, and like this one do not. Others do not. So that's kind of why they end up going with hydrocortisone a lot for replacement therapy here. This is the same thing if you look at the chart that says table 2. You can see the potency differences where 4 milligrams of dexamethasone would be very comparable to 25 milligrams of prednisone. Table 1, take a look at that too, because a lot of times, like I said, if these patients are on long-term steroid therapy, they have to adjust their doses according to a stress response. So if they were to have minor surgery, like such as a hernia repair, it would be 25 milligrams a day, and they'd only do it for one day. If it was a moderate surgery, like if it was a knee replacement or a hip replacement, depending on the patient, usually they'll do like a 50 to 75 milligram per day, and they'll have to do it for a few days. If it's a major surgery, such as open heart surgery, the patient requires a significant amount more. So they'd be at like 100 milligrams or to 150 milligrams for 2 to 3 days. So it kind of depends on what's going on with the patient. But it's important that these patients understand that they have to do this in order to make sure that they don't go into that acute adrenal crisis where they don't have any of these steroid hormones left. Now, in terms of diagnostic testing for adrenal cortical function, so you'll see ACTH used, the cosinotropin. Mainly what I want you to understand with this is that it's used for diagnostic testing, and it kind of helps determine whether it's a primary cause or a secondary cause, whether it's coming from essentially from the adrenal gland or if it's coming from a secondary area like the pituitary or hypothalamus. And it's basically looking at the patient's cortisol levels after it's given. And dexamethasone is also used for diagnosis. This is synthetic steroid, and I know we already kind of talked about this. And it's done overnight. They'll do a test to diagnose Cushing. This is for Cushing's. And it's they can even do a prolonged dexamethasone suppression test. So what they do with this is they measure their cortisol levels in the morning immediately following. Normally, the dexamethasone will suppress cortisol excretion so that the plasma levels will be at less than 5. So patients with Cushing syndrome, it's not suppressed by the single dose of dexamethasone. So their cortisol levels will be much different than it would be if it was a patient that did not have Cushing syndrome, essentially. So the only factor I want you really to understand with this is that it's also used for diagnosis. And I put this at the end too. It kind of describes the dexamethasone suppression test a little bit more, and you can just read that on your own. And I will put more information up on the Moodle book too that will kind of help clarify all this. And if you have any questions, just let me know. Thank you.